I'm gonna try in the next 20 minutes to give you a summary of where we are in terms of stem cell therapy for areas in female pelvic medicine and reconstruction. So it's a broad amount of literature I'm gonna try to summarize here for you. The goals will be to talk about stem cell therapy and for stress urinary incontinence, for pelvic organ prolapse, for interstitial cystitis, and fecal incontinence. The big bulk is going to be for urinary incontinence, which is where we have been working on for the longest amount of time, and we have more data and more human data as well. So at the time of vaginal delivery, there's significant injury to the pudendal nerve, tear or avulsion of the levator musculature, and ischemia that can lead later on to pelvic floor disorders, including prolapse and incontinence. In addition, there are changes that occur with aging, where there's atrophy of the skeletal rhabdosphincter, atrophy of the smooth musculature of the intrinsic sphincter unit in women, loss of neuronal mass, and with the lack of estrogen after menopause, there's decrease in vascular channels that help close the urethra. The vascular channels with the smooth muscle kind of help with the coaptation of the urethra. So there are many reasons why women leak urine. Anatomic lack of support, skeletal rhabdosphincter accounts for likely 50% of the continence mechanism in women. There's some studies that demonstrate that the smooth muscle, the intrinsic smooth muscle of the urethra, not only gives it tone, but it accounts for continence in about 40% of the continence mechanism. There's structural changes to the pelvic floor that occur with delivery and aging. There are changes in the sympathetic and parasympathetic innervation. There are pudendal nerve injuries that occur at the time of vaginal delivery, vascular injury. And again, there's a central nervous system component with how we coordinate avoiding. So the optimal treatment for stress urinary incontinence will be personalized to the particular injury that a woman is suffering, which is not the way we treat urinary incontinence right now. If we look just at one of the large clinical trials looking at randomized patients treated with mid-urethral sling, in this particular case, the Thomas trial, the look at TVT versus TOT. The only reason I put this slide here is to let you know that although we have great treatment choices for the treatment of stress incontinence, they're not perfect. When we looked objectively at this data, the subjective cure rate was between 55 and 62%. There's definitely room for improvement. And there are some complications that we're seeing, and this is short-term, at about a year after surgery. So there's room for improvement. What we do currently with our gold standard of doing a sling for patients with stress incontinence is that we kink and increase the urethral resistance. We provide backbore support. We can bulk with materials, but none of these treatments really improve the function, the ability of the urethra to close and open when it needs to do. So that has led many of us to look at alternative treatments to see, can we really improve the urethral function? So the goals of tissue engineering strategies for the treatment of stress incontinence have focused on replacing the atrophic smooth muscle or the skeletal muscle, improve innervation, and improve vascularity, with overall the idea will be to restore the function of the urethra. To do this, we need cells, maybe. We need a delivery system, maybe. We need a good animal model that represents the disease process. We need to show if the cells that we are using survive, what do they become, and to see if any of these areas that I'm arguing are important, vascularity and innervation, are really restored. And lastly, can we really restore the function of the urethra? So when we look at a definition of a stem cell, at the time of fertilization, the blastocyst has outside the trophoblast and the inner cell mass, which really provides a totipotent ability to develop an individual. In my case, my youngest son, which is now 14 years old. If we only look at the inner cell mass, is what we call embryonic stem cells. You cannot get a whole individual, you don't have a placenta, but you have cells that are totipotent or multipotent. These cells are immortal, they are identical, they can lead to long-term self-renewal, and they can differentiate into all cell types. And the stereotypical cell that can do that is the embryonic stem cell, and maybe some of the induced cells that can be induced to behave as embryonic stem cells. The majority of the research in stress incontinence has not been using these cells. The majority of the research today has been using adult-derived stem cells for a number of reasons. There are stem cells in every part of the body, and they're felt to be there to repair after injury. There's a lot of people looking at stem cells in this particular milieus, in these particular regions, looking at cancer. They are felt to also be involved in the development of prostate cancer and other things, but these cells are there for repair. The advantage of using them is that they can be expanded in culture. There's no significant ethical or political considerations. Because they're autologous, there's no need for immunosuppression, and this is a big one when we're dealing with a quality of life benign condition. We don't want to give a therapy where women would have to be immunosuppressed for life because we use a particular embryonic stem cell that doesn't belong to them. And they're multipotent, so they can become many issues. In terms of to summarize the preclinical studies that have been done to date, all these cell types have been used: umbilical cord stem cells, bone marrow, skeletal muscle that have a number of different names, skeletal muscle-derived cells, muscle progenitor cells, satellite cells. They're all pretty much the same cells. And adipose cells that have been called also a number of different names, adipose-derived stem cells or adipose stem cells. Bone marrow stem cells have been used in an acute model of urethral injury to give them intravenously to show that these cells can home to the area of injury. There's a couple of groups that have been looking at this kind of intravenous delivery of cells. I question the relevance of this model since the injury happened at the time of delivery, but really the symptom happens 2 or 3 decades later. But they have also been used for periurethral injection in more chronic models. And the data, as in almost all the preclinical studies, show that you can, in different animal models, in this case a bilateral pudendal nerve transection rodent model, that when you inject cells, you have increase in leak point pressure. The problem with bone marrow stem cells is the morbidity of the harvest, really going to the bone marrow to get them. And you obtain very few cells, and you have to expand them significantly in the laboratory. The majority of the research for the treatment of stress incontinence has been in the use of muscle-derived stem cell for the idea of repairing the rhabdosphincter. In this model, a biopsy is obtained either from the thigh or from the bicep. And the cells are then pre-plated. They have to be taken to the laboratory for about 30 to 40 days until you get a more pure population that you can use for research. There are over 10 studies looking at these cells and stress incontinence in rodents. And there's also studies using non-human primates and canine. There's a number of different animal models, so it's hard to compare some of these studies. Some use the urethrolysis by electrocautery model, sciatic nerve transection, and pudendal nerve transection, or models of simulated vaginal delivery. And the cells are usually injected in saline or HBSS, which is a saline-like substance, and the longest follow-up has been 6 to 12 weeks. Again, as in the previous data, in the upper left side corner, you have leak point pressure in controls and in animals that are injected with cells at different time points, and you can see that leak point pressure increases in the right side column in each one of these time points, which are the cells being injected. Studies comparing them to fibroblasts show similar results, except fibroblasts cause obstruction. I think this is really interesting research. It's pretty recent. Most of this is from 2016 and 17. With the use of primates, there have been about 4 publications with the use of primates. And the reason I think it's interesting is not so much the use of the model or the incontinence or the cells. They've been using skeletal muscle-derived stem cells and follow these animals at 3 to 6 months. But and they have shown, just like in the rodents, that there are increases in maximal urethral pressure, and that these animals have improvement in their continence 6 weeks after local injection. But they have been able to look at acute versus chronic. So when they actually do the injury but inject the animal 6 months later, which is really what we are looking at humans, the response rate is not as good. So in an acute setting, when you do the injury, you inject the cells and follow the animals, which is the ability we have in rodents. They see a response, but when they actually wait it out, leave the animal incontinent 6 months and inject them, the outcomes are not as good. They also have shown, as expected, very minimal response to intravascular delivery of these cells, some when the injury is acute, but again, almost none when the injury is chronic. And they have been able to look at other things that I think are going to be important when we transfer this to the clinic, looking at age. So older animals really don't do as well. Younger animals respond much better to the therapy with increases in ligament pressure. Stress, so they have, in monkeys, you can have the dominant monkey and all the submissive monkeys, so the dominant monkeys do better with treatment with stem cells and much better than the other groups. And body weight, the more obese the animal, the least well they do. So these are things, again, for us to start thinking about as we start translating this to the human population, things that are gonna be factors. So we talked about replacement of the skeletal muscle in a lot of this research. We have particularly been interested in replacing the atrophic smooth muscle of the intrinsic urethra, again, for the same aim of restoring urethral function. And many years ago, we started using adipose-derived stem cells, and originally in our research, we were interested to be able to differentiate these cells into smooth muscle and make them work like smooth muscle. We published this work in the Proceedings of the National Academy of Science. We're the first group to be able to differentiate these cells into smooth muscle with markers, and also this make sure that these cells actually contracted and relaxed to different pharmacologic agents as smooth muscle cells do. We also published on one of the first models of incontinence after the well-validated vaginal delivery model that was developed by Tom Liu at UCSF. We looked at erythrolysis, and this is a different reason. I was at that point interested in a model that was long-lasting. I felt that if we're going to use stem cells, if we're going to do any of this type of research, we really have to prove that we're doing something significant. And the problem I had with the vaginal delivery model is that it's a mild model that a lot of the animals recover with time. So I remember being really young and naive and spending a couple of days with Tom Liu, and after spending a couple of days there saying, I'm never going to convince anybody that with this mild model I do cells, they're going to get better. I need something more drastic. So we would develop a model to do that, and we spent a fair amount of time with the idea of differentiating these cells, delivering into the animal, and making sure they stay there and behave like smooth muscle cells. Well, we quickly found that if we just deliver them in saline, the cells are there, and after some weeks, they're not there anymore. And I think this is well known at this time in all type of stem cell research in every part of the body. And we have spent a lot of time working with biomedical engineering, and particular biomaterials that can help us differentiate these cells in vivo, keep them in place for them to do what they're supposed to do. And we are able to show that in different groups, when we inject animals with biodegradable beads, that these cells do hang around for a long time, and that beads provide immediate bulking effect, but that only the cells, the animals injected with smooth muscle differentiated adipose cells have increasing urethral resistance at 12 weeks, and that this translates in organ bath to actually contractility of the urethra, so that we can actually show for one of the first times that we can improve urethral function itself and contractility with animals that are injected with adipose stem cells that have been differentiated into smooth muscle. So the microsphere can provide the initial bulking effect, but the cells really is what is improving the function. There have been a number of different laboratories looking at adipose-derived stem cells. There are, again, a number of different animal models that have been used and different delivery systems. And all the rodent models show improvements in ligament pressure, and some have shown improvement in urethral function. As time went by, we were interested, really, are we gonna spend, is a patient going to give a biopsy and then you tell them come back in a month and this is going to cost all this money because you have to expand the cells? And I think this is a significant limitation of some of the things that are coming in the pipeline. And we were really working, can you do something in the operating room when you harvest the cell, you put them back in right there and then, so the patient goes home and you're done, you don't have to really expand the cells. So this whole step where we were differentiating cells into smooth muscle or something else, can we obviate that? It's also become more apparent that maybe you don't need the cells at all, that the cells secrete stuff that cause these paracrine kind of growth factors that can help localize the local stem cells, but also help with smooth muscle regeneration, skeletal muscle regeneration, and you might not need the cell. So a lot of what we are working on is to try to eliminate the expansion outside the body of cells and the differentiation, and maybe start working as to what is it that these cells do, and can we replicate that with injectable materials when we might not need to use these cells. So a slightly different way that other labs are looking at that, but people are looking at this in many different fashion to really try to come up with a product where we can help our patients. But there have been a number of human trials. The first one was published in 2007. It was a big deal at the AUA. It was published in Lancet. It was a study from Austria, and unfortunately, this was retracted due to IRB and other issues with the experimental protocol, which set the field back a little bit. But since then, there have been a number of studies. This is a meta-analysis published by a Polish group that looked at there's about 682 patients that have been injected with some sort of stem cell. And the results are pretty much similar, about a 40% improvement, 50%, 40%, 30% cure rate. Very few studies that have looked at long-term outcomes. There's about 15 clinical trials in clinicaltrials.gov using stem cells for the treatment of incontinence. The most important trials for the U.S. market, or for the U.S., is going to be are the ones affiliated with Mike Chancellor and Cook Myoside. The original studies were really looking at safety and looking at different cell doses, and proved that the higher dose, the patients tended to do a little better, but that it was safe regardless. Again, the light blue in the lower graph shows one leak. As you can see, the more number of cells that you inject, the more likelihood that you have less leakage. The second study they published from the same group was a randomized clinical trial randomizing patients with incontinence, so not in treatment arms, but just to different doses of cells, again, to look at safety and trying to optimize what is the number of cells you will need to inject to be feasible. And the last study that I'm aware of, it was presented at the AUA last year. I haven't seen the publication. I actually searched for it yesterday, and I couldn't find it, but it must be on the works. But it was presented at the AUA last year, and it was an abstract where they look at 143 women that were randomized to treatment or no treatment, or kind of a vehicle placebo injection. So they settled for 150 times 10 to the 6 cells, and a small group of patients also were randomized at receiving one treatment or a repeat treatment at 6 months. Unfortunately, this study was ended early because the placebo effect was huge. And this is some of the data that they have. Originally, in the left column, this is how they defined pre-study their outcomes. And as you can see, the placebo is the interrupted line, while the treatment is the solid line. And they were so close to each other that they have tried to play with the definition of improvement to try to separate those two groups. But as you try to separate them, you also decrease in who is a responder and who is not a responder. So it's unclear to me, but this is really going to inform them how to proceed with their phase 3, phase 4 clinical trials, but I haven't seen the details of the publication. So in summary, these are injectable therapies, which are a mixed population of cells. There's a number of animal studies that show improvement in urethral resistance. The clinical trials are promising. So if you ask me, have we made progress in the past decade and a half? Absolutely. Are we ready for prime time? I'm not so sure. We know that we're not going to use embryonic stem cells. We can't justify it for the treatment of stress incontinence. There's almost no research that's been done in induced stem cells. So it's most likely going to be an adult stem cell that have really been shown to be safe in the short term. In the long term, there's not a lot of durability efficacy studies. And when we look at the patient that we want to treat, looking at anatomic lag support, skeletal radial sphincter, and all the areas that we mentioned before, when we look at really patient-driven therapy, this is going to help patients that have muscle problems, nerve injury, vascular injury, really the anatomic or the central nervous system likely not going to be improve with this therapy. What I do want to say is that we really do not understand how these cells work, how these therapies work at any mean. And if we're looking at mechanism of action, we're really not ready for this therapy in terms of understanding it. But just because we don't understand how it works doesn't mean it doesn't work. It's being used in a number of conditions. In diabetes, it's being used in macular degeneration. And I do believe that even if we're ready or not ready, we're going to be seeing a product in the market in the very near future. Thank you.